Hello everyone, and welcome to another edition of the Understanding Sports and Exercise Medicine Research Show, the show that brings you the latest research straight from the horse's mouth. I'm your host, Tim Travail from Torrens University in Melbourne. Today we have an award-winning researcher for his PhD work, and someone who clearly not only understands biomechanics well, but the practical application for the clinician. Biomechanics plays an important part in the management of pain, injury and performance within the biopsychosocial framework. And it's really good to see this work from Matt that considers how this can and perhaps should be considered differently for men and women. Now, if you're anything like me and can get a little lost in the biomechanics detail, I'd recommend getting a copy of the paper close to hand as we talk it through. It's a little heavy at times, but well worth sticking with it. Okay, let's get into it. Hello everyone, and welcome to episode 3 of the Understanding Sports and Exercise Medicine Research Show. Today, I'm very pleased to be joined by the very soon-to-be Dr. Matt King, a physiotherapist from the La Trobe Sports and Exercise Medicine Research Centre here in Melbourne, Australia. Matt has just completed his PhD at La Trobe in the area of biomechanics of hip-related pain, with a specific focus on the identification and treatment of individuals at risk of developing persistent pain. Matt's work has come highly recommended by many, so it's no surprise to people familiar with his work that the paper we're discussing today won the John Sutton Award for Best Paper in Sports and Exercise Science at the 2019 Sports Medicine Australia Conference. So Matt, congratulations for the award and for recently completing your PhD, and welcome to the podcast.
Thanks, Tim, and thanks for having me to talk about some of this work.
Excellent. All right, so before we get into the paper, can you just tell the listeners a little bit more about yourself and your clinical and research background, and maybe touch on what you're up to now? Now you've just finished the PhD.
Yeah, certainly. So I'm a physio based in Melbourne. Currently, I divide my time up between the La Trobe Sport and Exercise Med Research Facility, and I'm also a clinical consultant to the Transport Accident Commission in Victoria. So I also graduated my undergrad degree from La Trobe in 2011 and started my PhD there 4 years ago. I suppose the decision-making process around, going into the hip as a young physiotherapist, it was certainly an area that I didn't have a large understanding of. It's not taught as much as, say, the knee and ankle rehab components in Australia. So it started to something that I started to look into. And then through a variety of chance encounters with some researchers, Tanya Bazari and Adam Semku especially, got into to meet Kay, and then the PhD kind of came from there. I suppose biomechanics. I've always been a bit of a maths and science geek. I'm very much a numbers person, and that's how that all came to fruition as well.
Good. I'm very glad you're very much a numbers person, because there's a few bits of this study I'm looking forward to hearing, and I'm sure the listeners will be, to when they're trying to read some of these papers. They can be a little bit challenging to those of us who aren't perhaps so heavily into those numbers and things. So it's great to have you firsthand being able to explain some of this stuff today. So thank you.
No problem.
So for the listeners, the paper that we're just going to touch on to start with is titled Lower Limb Biomechanics in Femoral Acetabular Impingement Syndrome, a Systematic Review and Meta-Analysis. Do you just want to touch on this paper, Matt, and just give us a bit of background and tell us what you found here?
Yeah, not a problem. So this paper started, obviously, like most PhDs, to determine what information is out there from a biomech perspective in hip-related presentations. Initially, this paper or this systematic review was initially aimed to cover both femoral acetabular impingement syndrome and hip-related presentations like labral tears and chondral lesions. However, or chondral findings. However, there isn't really much from a biomech perspective out there on those particular things. So we really honed it down into femoral acetabular impingement syndrome. I guess the main takeaways from this particular systematic review that we found were, firstly, most of the biomechanics research conducted in people with FAI syndrome is predominantly in walking. It's the most common biomechanical task investigated. Um, Secondary to that, and one of the main areas that we try to address in my thesis is the vast majority of papers that are included in the systematic review uh, were recruited from cohorts either seeking orthopedic opinion, either seeing or recruited from orthopedic surgeons' rooms, or they were scheduled to have hip arthroscopy. And secondary to that, which is kind of where another component of the clinical biomechanics paper that we'll talk about shortly, is the studies often utilised smaller sample sizes, but also amalgamated men and women together in their analysis. And we'll talk about that as we get to the intro of the clinical biomechanics paper. But basically what this paper found was, from a walking perspective, individuals with femoroacetabular impingement syndrome that are seeking orthopedic surgeon opinion or going to have surgery present with biomechanical impairments that are relatively similar at the hip to people with hip OA, albeit the size of those differences aren't as big as the OA literature, the differences in some of these joint angles. But that was the overall, I suppose, finding that the paper had. Then we wanted to really delve into, from a PhD perspective, well, if you know this information about individuals that are seeking surgery or seeking orthopedic opinion, what about the individuals that are still playing sport? What about individuals that may not have biomechanical impairments due to potential underloading from stopping from playing sport? And that's kind of where the PhD started to evolve, and where we just wanted to look at individuals with hip-related pain or hip-related groin pain and that were still participating in sport.
Okay, fantastic. I think that covers what we needed to, and that helps us see where you came from with that paper. So just to introduce the one we're going to talk about today. So the title is Lower Limb Biomechanics During Low and High Impact Functional Tasks Differ Between Men and Women with Hip-Related Groin Pain. And that's by, there was obviously quite a team of you involved there, obviously led by yourself. And Kay was your lead supervisor through that project, is that right?
Yeah. So Kay was my primary supervisor throughout my whole PhD.
Yeah. Okay, fantastic. I hear lots of good things about Kay and the research centre there. A bit of a powerhouse coming up.
She's one smart woman, that's for sure.
Yes, I've seen her talk a couple of times, and that certainly comes across. All right. So looking at the background context here, we've understood sort of your broadly why you came, what sort of the overall perspectives of your PhD were. And then more specifically, tell us why was this paper an important one within your PhD? What did you really want to find out from this paper?
And haven't necessarily thought about, and sometimes that can be an issue with small sample sizes as well, but haven't necessarily taken into consideration whether or not men and women with hip-related pain or hip-related groin pain move or have differing biomechanical responses to their pain presentation. So this paper ultimately set out to answer a very simple question in the broad scheme of things, and that was, do men and women with hip-related presentations move differently? And this started to frame, obviously, so this makes up the third paper in my PhD, and then frames my fourth and fifth one that came from that. It was really probably more a methodology paper for my PhD with a clinical twist on it to it as well.
Okay, and let's talk a bit about the study design now. So I think we've covered through the introduction. So you used a cross-sectional study design. Do you want to just talk a little bit about that, about why that was chosen, and a bit more about that design?
Yeah, so we just wanted to have a very basic and simple study design to compare men and women, and we just wanted to know, did these individuals move differently? So we didn't really have to worry about, I suppose, longitudinal components. We didn't really want to delve into the long-term effects of this presentation on their biomechanics. We literally just wanted to compare men and women, and the easiest way to do that from a study design is literally compare A and B at one particular time point.
I just want to talk about how you actually set up the design and the processes for the actual data collection that you were looking at.
So this particular study makes up a component of of the FORCE study, which is an acronym for the femoris tabular impingement and osteoarthritis study. So it's a prospective longitudinal cohort study that we're conducting in Melbourne and in Brisbane, in Queensland, Australia. And the components that made up my PhD were the first subset of individuals that were recruited in Melbourne prior to 2018. And we looked at individuals that, most importantly, had at least a 6-month history of hip and groin pain, and their pain had to be reproduced with a flexion, adduction, and internal rotation test. And most importantly, they had to be still participating in football. So soccer or Australian rules, but we really wanted to capture individuals that were still actively participating in competition. So these guys were still playing, state league level football, or VAFA for the AFL individuals watching, or metropolitan football leagues as well. Yep. Does that answer your question at this particular time?
Yeah, it does. Yeah, and because that just took us sort of onto the inclusion and exclusion criteria, and these were the same inclusion criteria from the wider FORCE study, the longitudinal study. That's correct.
Correct. Yeah, correct. Yeah. So basically, a 6-month history, positive flexion, adduction, internal rotation test, and we had a variety of exclusion criteria. We wanted to capture the individuals that had an insidious onset pain. We didn't want any individuals that had a self-reported history of any acute conditions or known diagnoses that have been provided to them. So fractures, bursitis, SUFIs, any developmental dysplasia, things like that. And then some standard imaging-based inclusion criteria. So any women that were pregnant or potentially pregnant were also excluded as they underwent x-rays.
Yeah. Okay, great. All right. So you've got your participants there, and do you just want to take us through then the actual biomechanics, the data collection that you were looking for from these? Because you talked before about walking being a large component of previous studies, and you've obviously included that as a component in this, and then you've got some other aspects of that. Let's just go on to the actual data collection component. So some of the prior studies that that you looked at mainly cover walking. And I know that you've included walking here and you've included some other components. So do you just want to talk us through what you were actually looking for in terms of data collection and how you set that up from a methods perspective?
Yeah, so we wanted to include walking so we could make a comparison to the systematic review, but we also wanted to include a task that had a higher vertical force impact magnitude, which is probably the technical way to say it, but basically a higher impact activity. And for a variety of reasons, we chose the single leg drop jump. And these reasons were around, although not commonly done in the hip space, the single leg drop jump is a common task performed in knee research. There's a fair bit out there, so we knew that we could get some normative data against that from previous studies and also look at some movement patterns that have been particularly studied in and around the knee or in controls. And the other reason we picked the single leg drop jump was it has a greater hip flexion angle than walking, and hip flexion is often a position that's reported as painful in these guys. As I said, as a higher impact task compared to walking, and secondary to that, it's a single limb task. Obviously, with walking, you have it's a bilateral task. You have a double support and single support surveys. Whereas this is very much a one limb activity, which is why we chose those tasks. As for the biomechanics model, in a nutshell for the listeners, this particular model that we used had been developed by one of my supervisors, Anthony Shack, and his time at Melbourne Uni, for a variety of other tasks that he had done, especially in running and sprinting. I can certainly elaborate on the technical side of the model if people wanted me to, but I think I'll just keep it at that for now. So we used that because it had been previously validated and shown to be reliable. And our biomechanics data collection for these types of studies, the participant comes in, they get changed. They wear a pair of running shorts, crop top singlet for the girls as well. They wear a pair of sandals, and that's so that they can have something on their feet, but also so we can still get to certain aspects of their foot to put some markers on.
Okay, I was when I was reading through the methods there, I was having a look and I googled those sandals, and they kind of look like your dad's pairs of sort of beach shoes, don't they?
Oh, yep, yep, they
And
are. They are definitely.
now I'm
We
being
actually
spammed. I'm being
struggled.
spammed on Instagram for bad sandals. Now I've googled those.
That's true. That's true. It was actually quite interesting because when we needed to replace them after we did some pilot testing, needed to replace a few of them. It was actually quite difficult to get them from Kmart. We thought we'd just go to Kmart and get some sandals. Turns out that Dad's sandals may have been in a couple of years ago, so we ended up having to get some shipped from overseas as well, which was quite interesting. Bit of a fun fact there. Um,
What was the justification? Why did you decide to use those rather than go barefoot for this type of testing?
Yeah, good question. So initially, when the model was validated, they were done in a similar type of sandal. So one around logistics, had already been validated with those type of sandals. Secondary for that, for consistency for individuals, um, was the second one. There's always in the biomech world contention and conversations in and around footwear choice, whether or not you go barefoot, whether or not you let them lose their runners. There's no one answer that satisfies all constraints. I just think it's important that people are consistent with what they do, and they're very, very transparent and clear about how they did it and the potential pitfalls that come with that. But I guess that's research in general, so to speak.
Yeah, absolutely. Okay, I think that covers everything you need to from that actual data collection component. Let's just drop down then. Before we jump into the results, should we just talk a touch about the actual plans for how you were going to analyze it? So is there any further information in this section 2.4 for the listeners, on top of what we've just covered there? Or is this what we've just talked about?
I think the only thing to potentially flag would be walking was very relatively straightforward. We took warm-up trials, 10 warm-up trials, and just to work out how fast they walk. And then when we had their testing trials, they had to land plus minus. They had to be plus minus 5% of their speed across the lab. And the single leg drop jump was just a standard single leg drop jump that you'll see in any sports medicine testing protocol, just from a 30 centimetre step. I guess they're the only two things to flag from there.
Standard.
Yeah.
Okay, and the walking pace was a self-selected walking pace, was it? Yep.
Okay. Yep.
Last couple of questions on the methods here. What was the most difficult component or most challenging component? There's quite a lot of technical components to all of that setup and different parts to it. What was the most difficult bit from a practical research perspective?
From a practical research perspective, it's data collection. You're dealing with large pieces of equipment that are potentially temperamental, and they're affected by different light conditions, and if there's movement. Our lab is actually in the basement of the building, so I think the biggest difficulty, if you've seen this research unfold or read some of the papers, was during the storms in 2007, our lab actually got destroyed. So we had a massive 7-month hiatus, and then had to have a lab rebuild as well. So that was probably the logistics, the most dangerous thing. And then, like all studies, it's about how the best do we analyse the data to answer the question, while still having good scientific rigour, but also making it clinically applicable at the same time. That's always a difficult question to ask and a difficult question to answer.
Yes. And in hindsight, is there anything that you would have changed about the methodology or the way that you put this study together, or are you pretty happy with it?
Not a couple of things. One, I would have recruited or kept recruiting to get more women. Obviously, when we talk about the numbers of the participants, there's substantially less women here. And the second thing with that, if I had hindsight and had time to go back again, I would take either a visual analog scale or a numerical rating scale of their pain during the task, especially the single leg drop jump. Unfortunately, we didn't do that when we collected the data. But I just think it probably would have added a little bit more clinical insight in this particular study moving forward. But
yeah,
hindsight's a beautiful thing.
Okay, so we'll progress on to the results now. So do you want to talk us through the main findings of the paper? And there's quite a bit to go through here, so I'll let
There's
you.
quite a bit. If I was to summarise it quite briefly, obviously we analysed the hip, the knee, and the ankle across the two tasks, and we used something called statistical parametric mapping in order to do it, and that allowed us to get some percentage of stance phase as to where the differences were. If we actually take a step back from the technical component of the analysis and the paper, I suppose simplify things down, the results really have three key points that they demonstrate. Firstly, men and women move differently. And most importantly, what we found joint-specific differences at the hip and at the knee. So the differences that were observed at the hip and the knee were not the same across the two tasks. And we found a joint-specific difference at the ankle. The differences between the men and women during walking were the same as the differences between the men and women during the single leg drop jump. Ultimately, the male hip and groin pain cohort used their calf more during both walking and the single leg drop jump. So it's not necessarily, the big take home for this particular paper is not necessarily the specific the specific biomechanical findings that are there. It's the fact that these differences do exist. And when we get to the discussion, we'll talk about that a little bit more. But that's, I suppose, the broad overview of the results. But I'm also happy to delve into the more specific ones as well. If there's particular.
What I'd like to understand and help the reader to understand what's happening here in these in your display figures, if that's okay. Can you give us a sort of broad overview of what we're seeing here and why it's important to display the information like this?
Mm-hmm. So we used a technique called statistical parametric mapping, which has been used in MRI imaging, the functional MRI imaging, a fair bit, and it's starting to make its way into the biomechanics space, particularly around biomechanics and EMG. And what this particular analysis is it allows you to analyze data as continuous variables, and you don't have to chop the data up. So sometimes in biomechanics research, or quite often, you chop the data up and look at peaks, like peak hip flexion angle, peak knee flexion angle, or total ranges of motion. And there are some potential pitfalls around doing that from time to time. There's a really good paper by David Kerry that looks at this from an acute on chronic workload ratio perspective, but ultimately we wanted to, I suppose, maintain the data as continuous across stance phase, and in doing so, we can give information around where in stance these events occur. So if we take, say, if we take the hip frontal plane angle there in the second, so it's the section A, the second column across. So this is the hip frontal plane. First one there on the left now. So this is the hip frontal plane angle during the stance phase of walking. We've got the female cohort in red and the male cohort in black there, and there's some shading for their standard deviations. So that's just the mean. The top trace is just the mean and standard deviation of this data across stance. And if we go down to the second, or the map, but the graph that is underneath it, this is actually the results of the actual analysis. And what this is doing is this is basically comparing all the different points along stance using a particular type of mathematics called random wave theory, random field theory, and while maintaining control of type 1 error. So we're not getting a greater chance of a result under 0.05. But what this does is where the line crosses that, where the line either drops below or above that big dotted line, it's classed as significant. So if you notice, there's a little section shaded in there. So basically that's saying that between in that area of stance, there's a significant difference between the men and the women, and that's roughly between 15 and 30% of stance phase. That particular section of stance phase corresponds with contralateral toe off. So instead of having results where you would just take the peak and say there's a difference in peak hip abduction angle during the stance phase of walking, we can say that there's a difference between men and women during 15 and 30% of stance, and this corresponds to contralateral toe off during stance phase. That's, I suppose, a statistical parametric map in a nutshell. So these results are read across two graphs. The top ones, or the red and black ones, look at the means and standard deviations, and then the actual results are the graphs underneath, and where the shaded area is, this is where there's classed as a significant difference between the two.
Okay, I'm personally very glad I've got someone like you to explain that as we go through this. When I first looked at this and read about statistical parametric mapping, it was certainly new to me, but coming with a bit of an explanation is very helpful.
It took me a bit of time to get my head around the theory of it as well, and continuing to learn about it, a little bit more complicated. But in a take home, it's the benefit of it is it gives you another component. It gives you, in the case of walking in biomech, it gives you a percentage of stance phase. Yeah. So you can start to tease out those differences a little bit more.
And why are we seeing two different p-values in this one as a quote?
So that is because, technically speaking, where that little
was that going crossing?
Yeah. So that crosses the line again, and then there's another section. Right. So you need to take take this information with a bit of grain of salt in and around how you interpret it. If you actually want to scroll down a little bit and have a look at the hip transverse plane moment. So if you notice on this particular one, there's two p-values. There's one down low and there's one up high in the transverse plane moment there.
Yep.
And that's basically saying that in one section, men are lower than women, and in another section, men are greater than women for these variables. But if you actually look at the mean and standard deviation traces, they have a relatively similar pattern. They're almost offset a little bit to the left or to the right. So when interpreting this data, you look at this particular graph and statistical parametric map, and because it's in stance phase and it's a little bit offset, you start to think, well, is this clinically relevant information, or is this just more an artifact of how it's been analysed? So as you read the paper, we notice we don't attribute too much of a difference towards this, just because firstly the transverse plane is incredibly is quite unreliable from a biomech perspective, and secondly the differences when you look at the whole story, the lines just maybe offset a little bit as opposed to being a true difference that's there. A bit of a brain.
I'm probably going to need to go back and listen to that a few times and reread the paper again, and then it might start to come together a little bit more for me. But that's usually the way my brain works. Yeah. So should we go through? I mean, the paper sort of lays it out, so it's probably worth us going in the same sort of order we've got in the paper here. So if we look at the main findings and discussion from the walking phase.
Yep.
Is there anything you want to talk about there?
Yeah, so looking at the hip and knee to start with during walking, I think another point here is we don't have a control group, so we can't attribute whether or not the differences are potentially just inherent differences between men and women, which we know exist a little bit during walking, especially, or during a lot of tasks, but walking is quite commonly analysed, or whether or not they're differing responses to pain or their presentation. So from a walking perspective, women were in a little bit more of an anterior pelvic tilt. They were generally offset in more of an anterior pelvic tilt by about 4 degrees. And they also produced a greater hip adduction moment and greater hip adduction angle through mid-stance and internal rotation angle as well. Now, these are relatively common findings in control populations of men and women. So it's unclear, are we just basically replicating the inherent differences between men and women, or, is the difference a similar response to their pain presentation? We're not 100% sure because we don't have a control population to compare that against. Or the other thing which has been also talked about in a couple of other walking papers that have come out more recently is the question around whether or not walking is a difficult enough task to elicit differences in young individuals still playing sport that have pain. That's the other question there.
You said, as you said earlier on, in what you might have changed if you had got a that VAS scale through that, you might have made those components. That would have been interesting.
Provided a bit of insight on that. Certainly would have, yeah. And then we're looking at the single leg drop jump from a hip and knee perspective. We thought we would have seen a lot more differences. We thought we would have observed greater differences between the men and women because of that high impact nature. And especially because pain-free cohorts, especially around knee research, demonstrate differences during landing type tasks between men and women. Generally women have a bit of a higher knee flexion angle, greater hip internal rotation angle. However, we didn't see too many differences in our cohort. They were relatively similar. There were some subtle ones at the hip, and men were in hip flexion. Men displayed a lower anterior pelvic tilt a little bit earlier. So, and when we compare this to I suppose, prior research, it was slightly different compared to those control studies that have been done. There were some differences in the moments in and around the knee. In particular, there was a larger external knee flexion moment during late stance in the knee. So the men used their quad substantially more during the task. So looking at this, I suppose, going forward, it indicates that potentially men with this particular pain presentation execute the task with greater loads on their knee extensors. They use their quad a lot more, especially in that sort of jumping phase as they come back up during the task. So it may attribute to different propulsive strategies during the single leg drop jump. The real interesting result here was actually at the ankle. So the same differences were observed at the ankle between men and women. And in a nutshell, the men used their calf more. They had a greater external dorsiflexion moment and impulse. So basically, they produced a greater amount of load at their calf during this particular task. Now, what that means going forward, we're not 100% sure. Potentially, look, and again, hindsight is a beautiful thing. Maybe incorporating some form of calf strength task in their clinical assessment when they were in may have provided more insight. Did the men have stronger calves or more power? However, calf may be calf strength and the ability for the calf to produce power may be a potential rehab target, especially for women with hip-related pain, if they're participating in tasks that have that high impact nature.
Yeah. Okay. Fantastic. And I suppose that brings us on. That's a good clinical insight there, and that brings us on to really the final question I wanted to touch on. If you're a clinician working with people with this hip related groin pain, what do you think this study adds for the clinician, and what's it most important for someone to take away and really apply to their athletes from this type of paper?
From a clinical perspective, if you look at I suppose the assessment and treatment arms of physio and rehab, the study demonstrates that men and women move differently. So my real important take home here is there's potential for women. So the recommendations and the findings from previous studies may not necessarily apply to women as much as they do men, mainly because the cohorts in previous research have a greater percentage of men in them. So ultimately, if you're assessing an individual, especially if you're assessing a woman with this particular condition, they may not necessarily present with the common biomechanical impairments that are noted in the literature. Secondary to that as well, the calf may provide some potential treatment interventions again for women as well with this particular presentation, but again, more work is needed in this area. Ultimately, we're attempting to determine, what are the biomechanical impairments in men and what are the biomechanical impairments in women that these individuals present with. Not necessarily the ones that are presenting with surgery, but the ones that present early in their hip pain presentation at the clinic. They're still playing, they've started to develop some insidious onset pain. How do these people look when they come in? And if you're going to incorporate movement retraining as a component of their rehabilitation, what sort of impairment should you be looking out for?
And so are these the questions that you're continuing to answer? Did this paper lead on to directly to the your fourth and your fifth study in your PhD, or were they slightly to the side of it?
No. So this led straight into paper 4 and paper 5. So paper 4 has just been published in MSSE, and we actually look at the relationship between hip-related presentations and biomechanical impairments, including the potential for sex to modify those relationships. And then paper 5, from a biomech perspective, I really like power. I think it's a real easy digestible variable for individuals for clinicians to understand. So the 5th paper, which will be submitted at the end of this week from a PhD, looks at power variables at the hip, knee and ankle and their potential relationships with these individuals' presentation, and whether or not that can provide any insight further down the track from a rehab perspective.
Okay, sounds interesting. We'll be on the lookout for those shortly. And so thank you very much for that. There's a lot of information in this paper. I can clearly see why it's been as successful as it was. And I think there's been some excellent insights to help us understand some of the complexities of a paper like this for people that perhaps aren't so biomechanics minded to still try and digest and understand this important type of work and work out how it can fit into their own clinical practice. So I really appreciate your time today, Matt, in taking us through this. And where can people follow you if they want to keep an eye out for what you're up to in your research?
Yeah, no problem. So I'm somewhat relatively active on Twitter sometimes. So my Twitter handle is MattGMKing1. And my email address is also on the paper, and I'm also happy for you to put my email address on the blog as well if people want to reach out and discuss biomech research or anything like that. The easiest two ways to find me.
All right. Well, I'll certainly add that and the links to your papers into the show notes of this. So, Matt, thanks again. It's been a pleasure.
Thank you very much, Tim.